Thank you, Dr. Sundeep, sir. We were colleagues and friends, wrote entrances together. Now, sir became big and professor of cardiology. I don't know how many of you know, their center is a leading center for the students or top ranks are picking up Safdarjung Hospital. First 24 ranks at cardiology seats are over there. So it's fortunate. Thank you for sparing your time and coming over to discuss with all of you. I requested him. Thank you, sir. Over to you for lecture.
Thank you, Dr. Srinivas, for this kind invitation. And my job over the next 15 minutes or so is to talk to you about a very common problem that we particularly face in our country. And that is the problem of delayed presentation, which is often accompanied by a high thrombus burden. So this is going to be the flow of my talk. We discuss what exactly is delayed presentation. We talk of how common it is and why is it important. Then we also talk of the familiar thing of thrombus burden. And then we finally see what are the drugs or devices and how do we go about managing it. This is a very famous diagram. This is a very famous graph that we all read in our textbooks. It is given in the Brown-Wald's cardiology. This is something that came almost 20 years ago by Dr. Bernard Gersh, and this actually shows the time relation to the time relation to therapy. And we all know that the golden hour is the first hour from the onset of symptoms, where if you move from D to C, say from D to C, there is a great reduction in mortality. And if you move from C to B, there is also a relative reduction. The time is up to 6 hours. And then there is a slower but definite reduction, and that is up to 12 hours. So anything which presents beyond 12 hours is actually called as late presentation. So this is currently the standard definition of late presentation. Anybody who comes beyond 12 hours, most of the data has come from animal studies and also from clinical studies. It has been seen that in animal studies, most of the benefit was lost beyond 6 hours. But when we went on to do, and this data is again mainly from thrombolytic therapy, it should be even better with BCI. But what we learned was that even up to 12 hours, there is a significant benefit. And therefore, why this happened? Because, in animal experiments, we just ligate the artery and look at how the infarction takes place. Whereas you have collaterals, you have, many a times the occlusion in the ST elevation related vessel is a dynamic or intermittent occlusion. So we get benefits up to 12 hours. Now, further down, how common is late presentation? In Western literature, the figure mentioned is between 10 to 20%, mostly between 15 to 20%. And at the bottom, I've mentioned the CREATE registry, which is the Indian registry of a couple of thousand of patients. And as we can see, the yellow figure in that, the yellow box, it says almost 1/3 of the patients in India with ST elevation MI. The figure of 42% is with non-ST elevation MI. But with ST elevation MI, almost 1/3 of our patients actually present beyond 12 hours. So with us, it is a very common problem. It has also been seen what are generally the clinical features of these patients. They are older, a lot of them are women, diabetic patients, particularly patients whose initial presentation is an atypical chest pain. And on the other hand, if a patient is a known case of coronary artery disease, has had a prior MI or PCI, then they tend to wait lesser. The single most important cause for delay is actually on part of the patient. We all know our patients, it's a natural human tendency also, which is exaggerated in our part of the world. People have a self-denial, mujhe to heart attack nahi ho sakta, and things like that. During the COVID, it was also seen that the delay was attributable to one other factor, that most people avoided going to the health services for problems other than COVID. They delayed the coming to the hospital. Switching gears, how about thrombus? See, we all know that whenever the plaque ruptures or erodes, there is an exposure of the subendothelial thrombogenic surface to the platelets. The platelets adhere to themselves, they aggregate, and a white thrombus is formed. After that, there is a concomitant release of tissue factor at the arterial injury site, and the external or the extrinsic coagulation cascade is activated. This leads to the red blood cells getting aggregated, and we get what is known as the red thrombus. So if my patient has had shorter episodes of occlusion of the artery, the predominant thing that we find, particularly in unstable angina and non-ST elevation MI, is a white thrombus. When the artery gets occluded, and it has been occluded for some time, the extrinsic coagulation cascade has been activated, we find the the red thrombus. And we also know a lot of other factors which are vasoconstrictive and aggregative factors. They accumulate over a period of time. This clot consolidates over a period of time, and then it becomes very difficult to disrupt. And that is the problem with delayed presentation patients. What is the frequency of large thrombus in ST elevation MI? In the Western literature, it is again 15 to 20% of the patients who present late have a large thrombus burden. And in the Indian scenario, this is a paper from Dr. Ranjit Nath, published in 2020 in Indian Heart Journal. About 16 to 18% of our patients also have a very large thrombus. Is it possible to predict that which are the patients that are going to get up or get a large thrombus burden? If the patients have a high syntax score, that has been correlated. If you have a higher troponin level and CRP levels at the baseline, these are associated with higher thrombus burden. An interesting thing that has been found, and this paper is a couple of months old in Medicine Journal, is this high CRP to albumin ratio. Any one of you who's going to take up thesis, this can be a very good thesis topic. CRP to albumin ratio, as a predictor of thrombus burden. It has been seen that it is a predictor of high thrombus burden. Besides that, if your WBCs are very high and you're presenting blood glucose is high, they are again predictors that you may have a high thrombus burden. Angiographically, when we do angiography, what we find is that what are going to be the predictor, proofs that the thrombus burden is going to be high. If there is a cutoff occlusion, if there is a thrombus which is occluding prior to the actual obstruction, if you find that the lumen of the infarct-related artery is more than 4 millimeters and incomplete obstruction, but the thrombus that you see is far greater than the greatest luminal diameter, or if you have floating thrombi, and like the proximal obstruction, if you have persistence of dye beyond the obstruction, that also is a proof that you are likely to deal with a large thrombus burden. How do you classify the grading of thrombus? This is the Stemi grading that we all know. It is given in the textbooks. And the important thing is that grade 4 and grade 5, when the thrombus is more than 2 times the diameter of the vessel, or there is a complete thrombotic occlusion, those are known as high-grade thrombi. So the other way in which people have used to classify the thrombus is low-grade thrombus, which is grade 1 to 3, and high-grade thrombus, which is grades 4 and 5. There is also a new score which has been published in 2022 from a Turkish group, and they give it a score which is called the MAF score. It's a very elaborate paper. I can't give you the exact score, but suffice to say that there are scores that exist which can tell you that the thrombus burden is high. So the next question, comes whether we should intervene at all in late presenters. And there is a British Cardiovascular Society editorial by Dr. Evelyn Brown. She shows that if you have any problems beyond 12 hours, particularly heart failure or left ventricular dysfunction, then it improves the survival if you do an angioplasty. Similarly, it has been seen that even in those patients who do not have heart failure or any major complications, stable patients between 12 to 48 hours, and this was an important trial called the BRAVE-2 trial, based on which the European Society of Cardiology currently says that it is a class 2A, not class 1, but a class 2A indication to be able to do angioplasty in patients of ST elevation MI between 12 to 48 hours. So what I practice in my center and what I teach my residents is that if your patient comes within 48 hours of myocardial infarction, you can go ahead and do angioplasty in those patients. There are other registries and large observational studies which again have shown that there is a benefit, not in terms of mortality. There are some trials which show mortality benefit also, but the major advantage is in terms of myocardial salvage. It has been seen that you can salvage up to 5% of myocardium. That's a sizable percentage of heart that you can salvage if you do angioplasty in these patients. There are other trials again which show that the salvage is better, with some showing plus minus benefit in terms of mortality. There is one randomized controlled trial, which not exactly randomized controlled trial, but a very selected trial actually, which showed that there is indeed a mortality reduction. If you take out the patients in the first 48 hours and you analyze them, this is from the US, they actually showed that almost 70% of them underwent only PCI and no thrombolysis. And there was a mortality reduction at 1 month, at 6 months, and even at 5 years, there is still a mortality reduction. What are the treatment options that we have? We have options of drugs that have been highlighted here. So please remember, whenever your patient presents to you with acute coronary syndrome, the first thing you do is give a 325 milligrams of Disprin, not Ecosprin. Please remember, not coated aspirin, it is the soluble aspirin. And we all know that the best aspirin in our country available is the good old Disprin that we should give, preferably dissolved in half a glass of water. And along with that, we need to give 180 milligrams of crushed ticagrelor, because it has been seen that if you crush it and give it, then the onset of action is much faster and the blood levels achieved are much faster. There are specific scenarios wherein GP2B3 inhibitors have been used. Anticoagulants, plus minus data, doesn't say much whether you should use unfractionated heparin, or you should use enoxaparin, or you should use bivalirudin, which is available in India but not so very well used. It is more used in the West. Vasodilators do help: nitroprusside, adenosine, calcium channel blockers given intracoronary like deltazim. And there is some role of intracoronary thrombolysis when you have nothing working. I tell my residents that the treatment of large thrombus is actually intracoronary thrombolysis and not anything else. We also have, the aspiration devices that Dr. Srinivas touched upon. In this particular scenario, where we have backs to our wall, our backs to our to the wall, uh, aspiration is the preferred strategy. It can be manual, it can be mechanical, such as angiojet or exciser. Laser is now available, and the role of embolic protection devices is not that great. So this is the this is the flow chart. If you get a thrombus grade which is 3 or 5 and you have achieved an antegrade flow, you don't need to do anything else. But if there is no antegrade flow, you go ahead with thrombus aspiration, and then you can do a direct stenting, or you can also have a deferred stenting strategy. Between mechanical and manual aspiration and therapies, this is a meta-analysis almost 10 years old, but this clearly showed that in terms of major adverse cardiac events, reinfarction, aspiration thrombectomy, the good old suction that we apply to our aspiration devices, that is good, whereas mechanical thrombectomies are associated with higher problems. This is an elegant paper from Korea, from the KAMER registry, Korean Acute MI registry, which says that the effect of thrombus aspiration may be having a U-fold relation. There is one randomized control trial, a small trial of about 150 patients, which actually studied the endpoint of microvascular obstruction using CMR, and it was seen that there was no great benefit. So plus minus benefit, it has to be individualized. Do we use intracoronary, GP2B3A inhibitors? Traditionally, abciximab has the best lytic property when given intracoronary. However, it is a costly drug, and it also has antibody formation, so it cannot be reused in the same hospital setting. Most popularly used are either eptifibatide or tirofiban, and they actually, if we look at the first 3 columns, they improve the flow characteristics. They improve the incidence of TIMI3 flow, the frame counts, and also the blush grade. So those are the benefits, softer benefits. Then comes this problem of deferred strategy. Deferred strategy has to be used in only, it is usable only in 1 to 2% of patients of ST elevation MI, but there is a prerequisite. Number one, the thrombus burden has to be high. It has to be a grade 4 thrombus. You can't do it in grade 5. And it is also not useful in grade 1 to 3. If you have a grade 4 thrombus, that means the thrombus burden is more than 2 times the diameter of the coronary artery, then and you have a TIMI3 flow. You don't do it in occluded vessel. Please remember, if you have a TIMI1 flow or a TIMI2 flow, you don't adopt the defer strategy. So high thrombus burden with a TIMI3 flow, that is the only place where defer strategy works. And this particular meta-analysis, which came last year, again showed that the deferred strategy can be beneficial in very selected cases. So I'll show you in the end a case that we did recently. A 42 years old male presented to us at about 13 to 14 hours with acute severe chest pain. His ECG was suggestive of anterior wall MI, and he was taken up for primary PCI. And as we see here, this is the right coronary artery, which is normal. This is the LAD, which had a very proximal obstruction, total cutoff. Then we wired it, and you can see the balloon coming up, because if you have a grade 5 thrombus, the first thing is to dilate it with a small balloon, a 1.5 or a 2 millimeter balloon, and then reassess and tell what is the severity of the thrombus. So here we can see there is a trickle of flow, but there is a heavy thrombus burden that is still pre-existing. So what we did, we dilated it with a longer balloon and a 2.5 millimeters balloon. Some flow comes, and then we go ahead, if you can see, appreciate the small dot moving here, that is our thrombus aspiration catheter. We do this and we get a better flow. We are able to implant a stent and we get a TIMI 3 flow. So we were lucky that we could get a good result in this patient, but in many patients, we are not that lucky. So finally, what are the European Society of Cardiology ST elevation guidelines in terms of delayed presentation? If your patient is presenting within 12 hours, no matter what the situation, the default strategy is primary PCI. For more than 12 hours with ongoing symptoms, if your patient has ongoing chest pain, if your patient has heart failure, if your patient has any arrhythmias, then again, primary PCI is recommended. If the patient has presented to you within 12 to 48 hours, so you can still go ahead and do a primary PCI even without complications. It is a class 2A indication. It is guideline mediated. In US, the guideline is up to 24 hours, but we should be able to accept what is more acceptable to us, and that is the European guidelines, which is up to 48 hours. If your patient is more than 48 hours, do not do an angioplasty in these patients. Your patients die. We all learn a lot from each other by talking to each other. And over again, a lot of my friends, a lot of my cardiology colleagues have told and informed that when they did interventions on day 3, 5, 6, they lose the patients. And again, what we learn from our peers, a lot of my peers have told me that it is the right coronary which bursts open. It causes more complications.